Hello, my name is Marty Pagel, and I'd like to present magnetic resonance imaging. This is part two of a two-part series about MRI, and this video will discuss image contrast mechanisms, and will also include applications of the images that are generated by those contrast mechanisms. So I'm a professor in the Department of Cancer Systems Imaging and the Department of Imaging Physics at the MD Anderson Cancer Center here in Houston, Texas. I've been performing MRI research for 20 years, and I've been in the field of magnetic resonance research for about 35 years. So I'd like to discuss how we make contrast most commonly with MRI based upon T1 and T2 relaxation. In the previous video about how MRI works, I described how magnetization is derived from a net of protons or hydrogen atoms that are pointing with the magnetic field, tipped into the XY plane, and then evolve in this spiral pattern to give the signal. Well, the rate at which the signal returns to the z-axis is known as T1 relaxation, or more formally, the T1 relaxation time constant for the tissue or the sample. Now, the different tissues return to equilibrium, return to the z-axis at different rates. So here you can see that normal tissue relaxes to equilibrium a little faster than tumor tissue. And in general, more liquid-like tissues will return to equilibrium slower than normal tissues, which return faster. So the greatest contrast between normal tissue and tumor tissue in this educational example is with a relaxed time for recovery of zero point 0.8 seconds. You can see that the amount of magnetization along the z-axis, and therefore the amount of magnetization remaining in the XY detection plane, is greatest at that time. If I collect signals very early on, they're both the tumor and normal tissue will look like the same amount of magnetization. If I wait an extremely long time, I also lose the difference in magnetization signal between those two tissues. Now, there's also T2 relaxation, which is the time constant for the magnetization to leave this XY plane. And this would be most easily described as the sinusoidal pattern along the y-axis or the x-axis as the magnetization is performing a spiral pattern going back to the z-axis. And so you can imagine that it's spiraling in the xy plane and going up and down along one of those x or y axes. And there is a decay pattern to it as it decays back to the z-axis. And so that decay is known as the T2 relaxation time. And again, there will be a point of great contrast between tumor and normal tissue. In this case, in this educational example, I made it to be an evolution time in the experiment of about 60 milliseconds, not uncommon at a lower field magnet. And in that case, if you try to collect signals very early on in this evolution time of the experiment, both the tumor and the normal tissue will look the same. Of course, if you wait forever, all the signal has decayed, so everything will look black. You won't be able to tell the tumor from normal tissue. But if you do choose an ideal evolution time, you can generate contrast between those two tissues. Now you may think, well, isn't T2 the same as T1? Because the rate of return to the z-axis must be the same as the rate of loss of signal in the xy plane. But that is unfortunately not the case, because you have to consider that there is an ensemble of spins, a whole group of spins or hydrogen atoms or protons in the tissue that are behaving in this way. And unfortunately, they may not behave all the same. After exciting all of the net magnetization into the XY plane, it is possible that some of the hydrogen atoms or protons have magnetization that spins a little bit faster than others. And so if I have everything spinning at 300 megahertz in the whole detection plane, well, there might be some spins that are actually spinning at 301 megahertz, others at 299 megahertz. That difference is actually much more extreme than what happens in practice, but you get the idea. Therefore, magnetization tends to fan out, and so you can actually get a sum of magnetization in the XY plane that totals zero, everything will cancel out, while nothing has returned to the Z axis. And because of that, T2 relaxation can be much faster than the T1 relaxation. You'll see that the time frame on the x-axis here for T1 is on the order of seconds. And here, well, it's the same units, but you can see it's in a very faster regime, typically measured in milliseconds. So if I time things in the experiment to have a time of recovery or a time of evolution, you can see I can get different contrast between different tissues. Now, this is just a normal brain, no tumor here, but you can see that if I wait a very short time in terms of TR and also a very long time in terms of TE, that would be this image here, right? Short T1, long for TE. And there's hardly any signal, right? I've allowed that signal to decay to near zero. On the opposite end here, you can see if I wait a very long time for recovery before exciting again and again, but I have a very short TE, so I'm collecting the very early part of this signal. Well, this image is extremely bright, perhaps the brightest on the whole page here, uniformly for all tissue. But you can see the contrast between different tissues is not great. The contrast is really when I have either a lot of T1 waiting, or I have a short TR and then a short TE, or I have a long TR and a long TE, T dictating T2 weighted contrast. And here you can see that the liquid-like cerebral spinal fluid compartments here are very bright relative to the more solid-like gray and white matter within the brain. Here the gray and white matter looks bright while the cerebral spinal fluid looks dark because it has not returned to equilibrium very fast. So here's a normal volunteer. This is actually a picture of my brain. Yeah, you can see how large my tongue is. Always a shock when I see this image. Here are the salivary glands. You don't get to see that very often now. And I've been told I have a pretty good looking brain, so I'm pretty happy about that. This is some T1 and T2 weighted contrast, ideally suited to see all of these different parts within the head. This does match anatomically. Here is a rat that was used in a toxicity study, and one of the kidneys became quite large over time. Tumor had started to grow into that tumor, into the kidney. You can see the other kidney over here is normal size. And by looking at ex vivo gross pathology, the rat was humanely sacrificed, and then this tumor was taken out. You can see that even the necrotic part of the tumor, which is very solid-like, had different contrast than the rest of the tumor, which is very liquid-like. And the tumors are growing very rapidly and do not have good cellular organization, and therefore tend to be a little bit more liquid-like in their consistency. So what you see is in the image is truly what you get in reality. Well, can we use this to our advantage? Well, I could apply or administer a exogenous contrast agent, something that normally does not exist in the body. In this case, it's a gadolinium in a basket-like molecule called a gadolinium chelate agent. Gadolinium has a lot of electrons that are not paired with other electrons, and so are very active magnetically. And as water molecules then pass by this gadolinium chelate, the unpaired electrons will cause the water signal to lose its excited magnetization and return to equilibrium very rapidly. So if I have a lot of this contrast agent at high concentration in a sample, the water signal will relax back to equilibrium more quickly than if I do not have the contrast agent. And you can see that this is dose dependent. 1 over the T1 time is R1, so that's the relaxation rate, and that is related to concentration with the exquisite linearity. And so now we can effectively measure the concentration of agents, although there are some assumptions along the way that compromise this quantification. And therefore, we can inject agents and measure how much they are in certain organs. And they do tend to like to collect in tumors, which then lights up the tumor in the image. You can also do this with the T2 relaxation time, where the magnetization is relaxed away from the XY plane faster than normal when there is contrast agent. and you can get T2 as well. The rate of relaxation is linearly dependent on the concentration of the agent. So that's great. Now we can inject contrast agents and make different tissues of different brightness. So what are we really measuring here? Well, here is the full equation for the dipole-dipole relaxation mechanism that dictates the T1 and T2 times, or 1 over T1 and 1 over T2. I'll take a moment so you can write down all of that in great detail. Okay, I'm just joking. Really, let's highlight what's most important here. And really, there's an R in these equations. That's the distance between the nuclei. So the closer the water can get to the gadolinium, the more relaxation you will have. And you can actually design agents that manipulate how close water can get to the gadolinium. And that can be used to your advantage to detect processes that cause agents to polymerize or depolymerize. Different configuration or conformations of the agents might be dictated by the pH or other molecules within the system. So you can start to detect molecular biomarkers by manipulating this R. Correlation time. How fast this molecule tumbles along with water in the system will dictate the T1 and T2 relaxation. And so there are research projects that have attempted to optimize the correlation time to get the most brightness out of these agents. Well, what is correlation time dependent upon? It's really the viscosity of the surrounding medium and also the molecular radius. So big, bulky molecules tend to tumble slower. They have a slow correlation time. So therefore, macromolecules such as proteins, especially structural proteins, tend to have a very fast T1 because they have a slow correlation time. And if you have media such as a muscle tissue, that tends to be more viscous than, well, let's say the liquid within the bladder, of course. So that will also dictate your T1 time and T2. So in general, the take-home message is liquid-like tissues have short correlation times. They tumble fast, so they have a long T1 and T2. Solid-like tissues have a long correlation time. They tumble very slowly, so it takes a while for them to have one rotation of their molecular structure, and therefore they have shorter T1 and T2 times, as shown on this diagram. This is also dependent on magnetic field strength. So at higher field 7 Tesla magnets, you will have the T1 and T2 relaxation time be long. At very short correlation times or very long correlation times, there's a sweet spot where the correlation time is a certain timing so that T1 is actually the lowest. And 3T has a different sweet spot where the correlation time would dictate the shortest T1 time for the T1. And so because of that, you will get different contrast at 3T clinical field versus 7T small animal magnetic field strength. And that can be surprising at first that a clinical radiologist will be used to the type of image contrast in a clinical magnet, and then you'll show them images from a small animal magnet on a mouse model, and it will be disconcerting because they're not used to that kind of image contrast. In general, T2 weighted contrast works well at 7 Tesla, while T1 weighted contrast works well at 3T due to this effect right here. And I'd like to refer to these two references for more information. So here's an example where you can inject one of these exogenous contrast agents with gadolinium, and it will perfuse into normal tissue and also into tumor tissue. But because tumors have rapid growth that causes immature blood vessels that have leaky properties to them, you'll get more of these contrast agents, as shown by these blue dots, to pass through the blood vessel wall and into the extravascular space of the tumor. So more agent will accumulate in the tumor tissue. And that's seen right here, where I've got a two-dimensional MR image of a mouse with a tumor growing on the back. And when I inject the agent, well, you'll see that the bladder fills up with the agent and actually gets very, very bright. In fact, after time, this could actually get a T2 effect because it gets so filled with material. But you also see that the tumor is lighting up because it's got good, healthy vasculature. It's a very viable tumor. Bad for the mouse, good for the tumor that it has good vasculature. Now, one day after treatment with an anti-angiogenic agent, an agent that will reduce the blood vessel patency or perfusion in the tumor, you'll see if we do the same experiment, again, the bladder fills up, but there's very little agent being taken up in the tumor. In fact, there's a necrotic center that you might be able to see there as well that's taking up no agent at all. So clearly, very easy to identify a tumor relative to normal tissue after injecting this agent. So these contrast agents are very commonly used for initial tumor diagnosis relative to normal tissues, and then also to check the relative change in that uptake of the agent before and after certain types of anti-cancer treatments. The agent can be used for that purpose as well. So here's a more quantitative look where the MR signal from what is called the arterial input function, or basically the blood vessel, is recorded, along with the signal from the tumor itself, as seen here. And these are not to scale. The amount of agent in the blood vessel is actually much, much higher, but I'm just showing that on the same plot here for you. And so then you can do quantitative analysis to measure the rate of transport from the blood vessel into the tumor, or the rate of transport from the tumor back to the blood vessel, which is known as K-trans and KEP respectively. Another way of thinking of this is that K-trans is the wash-in rate into the tumor, and KEP is the wash-out rate back to the blood vessel. And both of them can be informative for these types of studies. There's been a very active decades of research in this area to refine the pharmacokinetic models, take into account other assumptions and corrections. And to be honest, it still is a work in progress because the data from MRI is somewhat noisy and difficult to extract a lot of complicated information from this data because of the noise. And so largely, a lot of MRI is performed with just contrast enhanced MRI, just looking at one time point, such as the ones I'm showing here, to show brightness or not so much brightness, rather than doing the full quantitative analysis. However, if you do the quantitative analysis, you do get numbers, and you can see that without drug, with drug, with radiation, or with the combination of drug and radiation, you get different types of vascular perfusion, which can indicate what's happening to the tumor. In this case, the combination therapy was actually causing the greatest control of the tumor growth, reducing tumor growth. And yet, it was surprising in this case that the combination was actually causing the tumor to be more leaky. You would think that a leaky tumor could take up more nutrients and would be more viable. But in this case, the blood vessels were being blown away so badly that it was causing huge holes in the blood vessels that could not be repaired. And so this was catastrophic to the tumor, and the tumor was not able to grow. While the reduction in leakiness was only temporary with the drug or the radiation alone. So let's switch to another topic, functional MRI. Could we use hemoglobin, oxy and deoxyhemoglobin, as a contrast agent? That way we wouldn't have to inject an exogenous chemical that doesn't normally exist in the body, and we could just use the body itself as a contrast agent. Well, in this case, the answer is yes, or I wouldn't be showing you this slide, of course. Where in a normal state within, let's say, the brain, where functional MRI is often performed, we have a combination of oxyhemoglobin and deoxyhemoglobin. And so the blood is flowing through normally in this capillary bed around an artery, and everything is fine. If we increase the flow rate, stimulate, well, initially some of the oxygen will be taken up from the blood vessels, but then very quickly there'll be your body will recognize that more oxygen is needed in that part of the brain that is starting to think about something, and so you'll start to see more oxyhemoglobin within this portion of the blood vessel compared to the basal state, where you'll see right here I have fewer of these orange ovals compared to the purple ovals, right? So this increase in the oxyhemoglobin, decrease in the relative amount of deoxyhemoglobin, can actually be imaged with MRI because oxyhemoglobin is diamagnetic it is not a very good MRI contrast agent, while the deoxyhemoglobin has iron that is not coupled to oxygen and therefore can be exposed to water and looks like a little magnet within the large magnetic field of the MRI. It's paramagnetic, and therefore it messes up the magnetic field basically around that area. So this area has less mess up of the magnetic field and you get more stronger signal. Here you've got more deoxyhemoglobin, so you have more of the magnetic field being messed up here as shown by these lines. Therefore you get less signal. That can be seen here where if we have especially a T2 star weighted gradient echo acquisition, which is sensitive to iron, paramagnetic iron, you'll see that it's quite dark. And in fact, there's a blooming effect from that. And because of that, even small amounts of this paramagnetic iron, deoxyhemoglobin, looks dark, and you can pick up structures in the brain quite nicely. Well, we use this to our advantage. Again, the paramagnetic deoxyhemoglobin is dark, while the diamagnetic oxyhemoglobin is bright. So therefore, by having oxygen flow into an area, perfuse into an area that of your brain that is thinking and metabolically active and then consuming oxygen, the signal will go up. There's a sustained positive bold response, blood oxygen level dependent response, because you have more oxyhemoglobin, that is diamagnetic, and you have decreased relative amount of deoxyhemoglobin, which is paramagnetic. You actually get an undershoot or a dip at the beginning here because you're consuming the oxygen within the oxy and deoxyhemoglobin mixture within the capillaries. So you're getting more HBr, deoxyhemoglobin at first. Then your body overcompensates and starts getting oxygen to that part where you're thinking. And then there's an undershoot after you stop thinking. So we can do a control image of a patient's brain and have that patient think of something, a flower or your favorite football team or something, right? And then take the difference between the two and see the areas of the brain that are consuming oxygen. You can even do this as a time series over time and have the patient think of a flower or their favorite football team and then have them not think about that and then go back and then not think about it and so on. You can do other physical activities too to cause the brain to be stimulated. Have the patient smell a certain scent or tap their finger on a table and so on. And so you can watch this time series. And because you know the series of stimuli that you gave to the patient, you can then map that onto the change in signal to clean up the data and get even better images than you did with just one time point over here to the left. You can see the right is much better. So with this repeated stimulus, I'll just move ahead here. You get the ability to track all of this in time and a really exquisite control over a lot of these parameters. You can model the dip and the post-stimulus undershoot to get further information as well. And so this field of functional MRI has been tremendous for understanding neurology. And so there are a variety of spots within the human brain that have been mapped that become stimulated and consume oxygen and get change in the MR signal or MR image based upon memory. Here's eye movements, motor control, physical motor control, touch with your hand. Grasping is a different area of your brain relative to actually touching. Areas, if you detect motion near your head, this part of your brain will start to think and consume oxygen relative to motion perception in other ways, right? Um, the part of your brain that is active when you identify faces is different than when you identify other objects. Quite amazing, isn't it? And then here's a study conducted by Janet Husband in the UK, the United Kingdom, where she was studying the effects of pain and where different parts of your brain consume oxygen and become metabolically active when experiencing pain. In this case, she just placed the patient's hand in water that was, well, mildly warm at 33 degrees or extremely warm, very hot at 61 degrees Celsius. And you can see there are different parts of the brain that actually do become active in different ways. In fact, there are fewer parts of the brain that are active at very high temperatures with more intense pain, but they are more acutely active than the more general activity in a larger area at 33 degrees. So here's the key. While not shown here, she tested normal patients and she also tested rugby players in the UK. And she was able to show that the brains of rugby players are wired differently and they can experience greater levels of pain or different, that when they do experience pain, different parts of their brains light up. So their brains are wired differently to take pain, which, if you've played rugby or you've seen rugby players, is probably not surprising. So here's another contrast mechanism. In this case, arterial spin labeling is performed by exciting a plane of magnetization, in this case, right below the brain in the brain stem area, and so, or in the blood vessels leading into the brain. And so that magnetization is excited, but then the magnetization is not detected in that same plane. Instead, it is detected in these other planes as the blood flows into other parts of the tissue. So you have a labeling slab, you have imaging slices, and by doing a control image where there is no labeling slab, then you can subtract the two images and see how fast the blood flows into the brain area. And so this is labeling via magnetization and excitation, the spins within the arteries, the arterial system, and watching where that goes into the brain. That's how you can get perfusion weighted imaging and cerebral blood flow maps in this way. Here is continuous arterial spin labeling, also known as CASTLE, where a patient was tapping with their finger on and off and on and off. And you can see that there was a stimulation of flow into certain areas of the brain due to that finger tapping. And then you can see these areas are where the finger tapping had the flow changed the most. So by comparing this with the previous functional MRI methodology, you can see different types of brain function, of course, right? Here's cerebral ischemia, where you can see that there is blood vessels that are closed and cerebral blood flow maps that can be made with this arterial spin labeling technique. And then after some follow-up, you can see how that can change over time for a patient. So clearly there's great diagnostic information about brain blood flow with ASL. Really a clever technique. Let's switch to diffusion weighted MRI. How does that work? Well, as shown in the first part of this two-part series, again, we have magnetization that's been excited from the z-axis, and that net magnetization ends up in the xy plane, and then spirals in the xy plane and returns to the z-axis, not shown on this diagram. So let me do an experiment where there is no diffusion of three protons, blue, yellow, and green at different parts of this mouse, right? Well, if I were to apply a gradient along the mouse, there is hardly any magnetic field here at the tip of the nose. And so this magnetization didn't experience any extra magnetic field. So it stayed where it was originally. Well, there was a little bit of a magnetic field at this part of the mouse. And so because of that, the magnetization responded to that magnetic field by rotating by 90 degrees. It saw that there was a magnetic field nearby, an extra amount. And so as you have more magnetic field, you have more megahertz as described in part one of this series. And so there was a rotation, a phase rotation. And then at the tip of the base of the mouse here, there's a large magnetic field, so it rotated by 180 degrees in this educational example. What happens if we reverse the gradient? Well, no surprise, everything is rephased. We've redone or undone the initial gradient by applying a reverse gradient. Now, if we go ahead and collect our MRR image like normal, everything will look the same as if we never even did this. Turn on the gradient and then do a reverse gradient, right? Everything will look normal. Now let's do this experiment with diffusion. I'm going to do the same thing and first apply a gradient so that I basically label the phase of the magnetization from tip of the nose to base of the animal. And so I've now mapped out the position along this axis along the mouse, labeling the protons with their phase. Now let me allow those water molecules or those protons to actually move inside the mouse. due to just random diffusion processes. Now what happens if I apply that reverse gradient? Well, you'll see that the blue proton is no longer where it was during the first gradient. So it is no longer rephased 100% back on the y-axis, right? It has moved during that second gradient that was applied. In fact, it moved in the opposite direction than the first gradient, right? The yellow proton did not rephase completely, and the green proton also did not rephase completely as well because of this motion along this head to tail axis of the mouse, right? Now, if I were to do MRI based upon the magnetization of magnetic state of these vectors, well, I would not get the same image, right? In fact, I've lost some coherent magnetization in this whole process due to this random physical motion due to diffusion. And so that's seen here, where if you have restricted diffusion, you really get the normalized MR signal to be about the same as if you didn't do this whole diffusion weighted experiment, right? There might be a little bit of diffusion, but you've restricted it quite a lot. Normal diffusion, these water molecules with hydrogen atoms or protons can move around a lot, and that causes a major loss of signal. Well, this rate of loss of signal is known as or can be mapped out according to a so-called B value, a parameter that you can change in this diffusion experiment with MRI. And then this rate of this loss can be calculated, and that is related to the apparent diffusion coefficient. So we can measure diffusion in a glass of water with no barriers around the water molecules in a homogeneous glass of water. But if we start to put barriers in the way, now the diffusion of the water will look like it's decreased, and we call that apparent diffusion. Well, why is that important? In normal tissue, there aren't too many cells. And so because of that, the water molecules inside the cell and especially outside the cell can actually move or can diffuse large distances. So the apparent diffusion coefficient can be quite high. But if you have increased cellularity due to tumor growth, and a lot of tumor cells are then growing out of control, and a lot of barriers in the way with all these cell membranes, now the water molecules cannot diffuse very rapidly. They're inhibited by these cell walls. And because of that, the ADC looks much smaller. So here's a map of the ADC. And you can see that there's a tumor here. The brightness is the ADC parameter, which is high for normal tissue. It's low for tumors. And so you see low ADC values in this area, which correlate with the tumor location as measured with another imaging method known as PET, measuring the amount of radioactive glucose that's taken up. And tumors love glucose. So this is a sign that there is a tumor here, and it matches very well with the diffusion weighted MRI. What happens if we apply treatment? Well, now those tumor cells are dying, becoming apoptotic or necrotic, and are leaving the system. And that causes a lot of open space for the water molecules to perfuse, and you'll actually see the ADC, the diffusion coefficient, increase. So over time, as this tumor model was being treated with the drug, we saw that the tumor ADC increased pretty consistently over time. It's a very small effect, and so you have to be very careful on how you do this experiment and be very quantitative about it. And I'll refer you to this publication by Kobus et al. For more detail. Let's move on to chemical exchange, saturation transfer, one of my favorite contrast mechanisms. So how does this work? It works with the physical exchange of a hydrogen atom or proton with a proton on water. But first, let's look at the signals from the amide or amine NH protons on proteins relative to the water signal. Or this could be an exogenous contrast agent as well. And so I'm not showing these to scale, but I'm showing that there is a net amount of magnetization pointing with the magnetic field versus that against the magnetic field. This is certainly not to scale, as I've pointed out. Almost all of the magnetization that's pointing against the magnetic field on top of on the top part of this diagram at high energy is almost canceling out all of these magnetization vectors that are pointing with the magnetic field. So I've made this diagram a bit out of balance for the educational purpose of this presentation. But there is a net pointing with the magnetic field versus against, and therefore I do get to see a net signal. Same with the water over here. Now what happens if I apply radio frequency saturation and scramble the net coherent magnetization from this proton? That would be like equilibrating this diagram. So now there is no net magnetization pointing with the magnetic field. They totally cancel each other out. The low energy and high energy states of the magnetization of this proton. Well, now let's have this proton exchange with water. And when that happens, we exchange some of these magnetic moments between the water and the water resonance here in blue versus the amide here in red. And you can see that, yeah, we might have re-picked up some of the net signal from the amide, but we've lost signal from the water. The water looks like it's decreased because some of this saturation effect from the amide has now been transferred over to the water. And if we do this for a lot of water molecules, this amide to water transfer can occur quite rapidly at 100 times per second, 1,000 times per second. You can really build up a lot of water molecules that look like they've been affected by this saturation effect. So this is chemical exchange of the protons, which then transfers the saturation from the amide that has been irradiated with radio frequency energy over to the water. Another way of thinking of this is that if you were to apply a 90-degree pulse to the magnetization of this amide proton here, you would then excite it into the XY plane. Well, what would happen if we applied a 36,090-degree pulse? Well, this magnetization vector would go around 36,000 degrees and then another 90 degrees and everything would still be fine. Okay, so that's what happened when we apply a low power pulse, often measured in terms of a microtesla, for 1 second or even longer. It just goes around and around and around in this ZY plane and it eventually ends up on the Y-axis. But what happens if there's a little bit of error? Well, now you no longer have everything along the y-axis. You have some of these vectors pointing along y, but you also have spread them out by plus or minus 180 degrees. Plus 100, minus 180 degrees. And all of this in red cancels each other out, showing that there is no net coherent magnetization that can be detected from this amide proton. So that's another pictorial way of considering saturation. What is this idea of saturating a signal? It sounds like a sponge that took up a lot of liquid or something, or you saturated the sponge. Well, it's not quite like that. Really, we're just removing all the coherence of the magnetization so that there's no net signal, and that gets transferred over to the water. So here's an experiment that we like to perform in our own research program, where we have a molecule called iopamidol that has these NH or amide protons. And we also have water molecule that can be near this amide proton. Well, I apply radio frequency selective saturation and scramble or remove the net coherent magnetization of that hydrogen atom. Then exchanges over to water. Now the water signal looks like it has gone down. Let's do an experiment where we place this molecule in this inner tube, and then we place the tube inside a larger tube that does not have the agent. Well, in the inner tube and in the outer tube, there's nothing at 15 ppm, a chemical or an NMR frequency known as 15 ppm. We only have water that's defined at 0 ppm, and we have these amide protons that have frequencies of 5.6 and 4.2 ppm. So the water signal in the inner tube is the same amplitude as the water signal in the outer tube. There's no CEST effect going on for this data point right here at 15 ppm. Now let me do a series of images here where I'm collecting one image after another, where I'm saturating selectively at these different frequencies. And yeah, if I were to selectively saturate this inner tube at 5.6 ppm, now I'm causing a scrambling of the magnetization of this hydrogen atom that transfers to water, and this is the water signal in the inner tube that looks like it has decreased. Hasn't gone to complete zero, but it has decreased, and we can measure that. I'm going to play this movie again, and you'll see that if I saturate at 4.2 ppm, this tube is going to get bright and dark as I go away from the frequency of this hydrogen atom here, and I go towards the frequency of this hydrogen atom. So if you watch this tube, I'll play the movie. It got brighter and it got darker again. And sure enough, we can map out the brightness and darkness and see that there's another peak forming in this spectrum. And then, of course, if I saturate exactly at 0 ppm, well, that's the MR frequency of water. So I scrambled all the water signal in the inner tube and the outer tube. And we do like to take a symmetrical spectrum, perhaps not with so many dots as I've done here, so many frequencies that are being saturated, but for educational purposes, we show a very detailed spectrum here. And then there are a variety of ways to fit the data. In this particular case, this hydrogen atom here actually loses its CEST effect as the pH increases, as the amount of acid within the system decreases. And this CEST effect here at 4.2 ppm actually increases as the pH increases. And this is because OH hydroxide ions like to come by and pluck off these hydrogens at high pH. So as the pH gets higher, the chemical exchange rate increases for both of these protons. Well, the proton at 5.6 ppm is already exchanging relatively fast and is at a good rate of exchange to generate a good CEST effect. But if I make it go too fast, it will then be too fast to actually generate CEST, transfer over to water, and carry its saturation effect over there. So we lose CEST from the proton at 5.6 ppm. While the proton at 4.2 ppm is actually exchanging too slow. And by increasing the pH, we have more hydroxides, OHs, that can come by and pluck off the hydrogen and form H2O. And the 4.2 ppm proton then falls within the so-called chemical exchange rate window much more nicely, and we pick up a better CEST effect. So this decrease and increase in the signal can be used in a ratio that is related to pH. Now we actually like to do more sophisticated data analysis than just making a linear graph, but back in 2014, that was a pretty common way of measuring pH. And you can see in this example here, we've got proton or a tumor model that has low pH. There's a lot of acid within tumors. Here's an infection model that can actually be a little bit alkaline at times because of the production of urea and ammonia from infectious diseases or from bacteria that are in infections. So because of that, you can tell the difference between lung infection and lung tumor with no problem at all. A really huge statistically significant difference between the two. In fact, this infection here was the most acidic infectious lesion, and this tumor was the least acidic tumor of the whole study. And you can see we can tell them apart extremely well. So now we have a measure and method to measure the amount of acid or to get the pH value of tissues within mouse models. And there has been some translation of this to the clinic as well. But that's not all. Now you can selectively saturate the amide proton within a protein and see this physical transfer of the proton to water. And that's known as the amide proton transfer effect when you're looking at the amide protons from proteins. So you can get an idea of the protein content within tissue by doing this experiment and seeing how much of a CEST effect you can generate here at about 3.5 ppm. There's also a relayed nuclear, and in fact, if I were to play that movie, you can see that there's selective saturation and there's transfer over to the water, just as I've shown before. There's also a relayed nuclear Overhauser effect, where I can selectively saturate or scramble the coherent magnetization of a proton, a hydrogen atom attached to a carbon. Now these hydrogen atoms do not leave the carbon atom. They're tightly bound to the carbon, so they cannot hop over to the water molecule. Instead, due to a through space effect, this excited hydrogen atom can relay its energy over to an amide proton, this hydrogen attached to a nitrogen. And then just like shown over here on the left, this hydrogen atom now can exchange with water. And so we get a relayed nuclear overhauser effect are relayed NOE over to the water. And that's this feature here showing that there's a decrease in the water signal due to the aliphatic protons within proteins as well. And that can be used to identify the amount of structural proteins in tissues, a little bit more than over here, which is more sensitive to the smaller sized proteins within tissues. It's also a standard nuclear Overhauser effect as well, where the magnetization can be excited from a hydrogen and directly passed over to the water, not shown here. We can also do magnetization transfer, where the radio frequency is excited on this aliphatic proton, and then through space, just as over here, we see scrambling of the magnetization or loss of coherence of the magnetization on the water itself directly. And then you can also do water suppression techniques and just get rid of the water signal. And by doing all of this, you can get an idea of total proton density of the tissue. You can do magnetization transfer from the semi-solid proteins over to the water, and you can do even water suppression and just see the non-water protons, which tend to be from the proteins or lipid materials. And this happens to be the human finger joint. So just think of your own finger right now, and deep inside, underneath the skin, that's what it looks like right here. And you can actually see the synovial fluid between the two bones in the joint within your finger. That synovial fluid has a lot of proteins, and so you pick up a lot of proteinaceous magnetization transfer effect here. And if you were to suppress the water, you can see a lot of the water within the tissue nearby is also decreased. So you can see this joint area within your finger. And you can imagine that those patients who have finger joint problems, this is an excellent imaging method. Oh, and then of course the nuclear Overhauser effect is shown here, again, similar to these other mechanisms. So there are many assessed sources. Some are endogenous within the body already. We don't have to inject anything. That's shown in black. And then there are the exogenous contrast agents that can be injected into the body, including even glucose can be injected intravenously and detected using these saturation transfer effects. All right, as another mechanism that has grown in popularity, what would happen if we did a chemical reaction to change this diagram where we have very little net magnetization pointing with the magnetic field, and we actually have a lot of magnetization against the magnetic field, canceling out most of the magnetization with the magnetic field. Under normal conditions, we have very little net magnetization. But if we do a chemical reaction and have all of these protons pointing against the magnetic field, a lot of them come down here and point with the magnetic field, we get hyperpolarization, and we can get a tremendous increase in signal. Well, how do we do this chemical reaction to do hyperpolarized MRI? Well, first we add a free radical, a molecule that has a unpaired electron, so the electron is quite reactive. And we add that to a material, often pyruvate, that has a carbon atom that is a carbon-13 isotope. Carbon-13 is the isotope of carbon that can be detected with MRI. It has a proton in the carbon that can be detected. So we add these together, place in a microwave, place a microwave in a freezer. We actually cool it down to nearly absolute zero at 4 kelvins. And we place that freezer in a 5 Tesla magnet because we need a magnetic field in which to orient the proton magnetization. And we wait a couple hours. Sometimes this can take as short as 45 minutes, but the longer you wait, the more of this reaction will occur. And then we have to inject the sample with hot pressurized solvent, get it back up to room temperature or even 37 degrees body temperature, perhaps even check the pH extremely quickly. And then we only got 2 to 3 minutes before the magnetization returns to equilibrium and goes back to the initial diagram that I showed. So you got to rush over to the patient, inject, and get all your signal right away. Here's a clinical hyperpolarizer, kind of looks like a vending machine where the material comes out ready to go. It's all been validated to be safe for patients, and then you can inject that into a patient who is sitting or who is residing in a clinical MRI scanner. Here's a preclinical hyperpolarizer. Looks similar, but a little more compact and doesn't have as much of the quality assurance, quality control built into it as you would for a clinical machine. And that can be injected into a mouse that's placed inside a preclinical MRI scanner. You do need detector coils that detect carbon-13 rather than hydrogen atoms or protons, which is a substantial cost, but those are readily made now. And then if you have money, well, if you have a lot of money, you can pull off this experiment with this rather sophisticated chemical reaction and these coils, and you can start to get extremely large signals. Here's the signal to noise of hyperpolarized pyruvate as being extremely large compared to non-hyperpolarized pyruvate, which is barely viewable. Um, this is all from Jim Bankson here at the MD Anderson Cancer Center, and also some materials are from Stanford University as well. So I'd like to thank Jim and Dan Spielman for this material. So as Jim has showed, if you and others as well in the field, if you have hyperpolarized C13 pyruvate, it will be converted to lactic acid within tumors. And you really do appreciate this graph showing the increase in pyruvate signal. We'll watch this again. Initial pyruvate burst of signal within the mouse after injecting this material, but then metabolically it's converted to lactic acid pretty quickly, lactate. And so the pyruvate and lactate can be detected separately from the MRI, especially if it's hyperpolarized and has a very large signal. And so by detecting different conversion rates, here's a case without a certain gene turned on so that the pyruvate to lactic acid transition occurred pretty quickly. Here, or without, I'm sorry, the gene was off. Here the gene is on, and you can see that destroyed largely the conversion rate of pyruvate to lactic acid. So you can start to see metabolic effects within the body. Wow. Well, that was quite a rapid survey of contrast mechanisms and to show some applications. I really want to thank the people in my research group over the many years at Case Western Reserve University, the University of Arizona, and MD Anderson Cancer Center in our research group known as the Contrast Agent Molecular Imaging Laboratory, who have helped me to learn about MRI over the years, and I hope I've helped them as well. So thank you.